Hello, welcome to the EKG Guy. If this is your first time, I'm glad you're joining us today. So in a recently published review in the Journal of the American Heart Association, we revisited the hallmark EKG features of ventricular tachycardia. They're shown in this figure, and we've been going through them. I've also placed a link below in the comments that you can simply search for to have access to this figure. Now, in general, wide complex tachycardia differentiation methods comprise one or more EKG criteria that embody distinctive electrophysiologic properties of ventricular tachycardia and supraventricular wide complex tachycardia. Available methods today that we use to interpret on the EKG examine the relationship of atrial and ventricular depolarization, that is, the presence or absence of AV dissociation, and we looked at that previously. And then they also look at the QRS morphologic criteria, which is this one here in our focus today. They also look at the QRS duration, chest lead concordance, QRS axis, ventricular activation velocity, and comparison to the baseline EKG. So there's no criterion or criteria that comprise or give us actually diagnostic certainty, but these help us get us closer, okay? And when you take the patient's clinical context and history, it even gets you closer, all right? So these are some things. Now in this lecture, we're gonna focus on the importance of the QRS morphological criteria in differentiating wide complex tachycardias. So this one here. And here's the article, okay, if you want to take a look at it yourself, and you'll have access to this image here if you would like. So let's get started. Assessing the QRS configurations, in particular the EKG leads, may provide clues to whether the wide complex tachycardia has a ventricular or a supraventricular origin. The pioneering works put forth by Sandler and Marriott, Wellens, and Kindle, collectively known as the classical morphological criteria, have added tremendous value towards the diagnostic evaluation of wide complex tachycardias. Now, in general, the primary purpose of using the morphological criteria is to identify QRS configurations that are either consistent or inconsistent with aberrant conduction. If a wide complex tachycardia demonstrates a QRS configuration incompatible with a typical right or left bundle branch block pattern, then ventricular tachycardia is most likely the diagnosis. For instance, if you have a ventricular tachycardia, it would be most likely demonstrating an atypical right bundle branch block characteristic, such as, what would this have? Well, you may see a monophasic R wave in V1 or V2 and a QS pattern in V6. Okay, so an atypical right bundle branch block pattern, if the one that we just mentioned, would be this one here. Okay, so here's VT with an atypical right bundle branch morphology, the monophasic R wave, okay, that you can see in V1 and V2, as well as the dominant Q wave, this one here, you're seeing in lead V6. Okay, so that's one configuration you may see. It's not that typical right bundle branch block pattern. Now, conversely, if a wide complex tachycardia displays QRS configurations representative of a typical right or left bundle branch block aberrant conduction, okay, then supraventricular wide complex tachycardia is most likely the diagnosis. For instance, you would have a supraventricular wide complex tachycardia, or it would be more likely if you had the classic left bundle branch block pattern where you had an R wave onset to S wave nadir less than 60 milliseconds in V1 or V2 and a notched monophasic R wave in lead V6. Okay, and we can see that typical pattern of a left bundle branch block here. Okay, so you can see the monophasic broad R wave in this left lateral lead V6 with that, and you can also see this terminal deflection here that's quite slow and slurred here in V1. Okay, this S wave, almost a QS complex that you're seeing in that lead. Now, there are a few notable exceptions to this concept, okay, including bundle branch block reentry or fascicular ventricular tachycardias, each of which engage the His-Purkinje network and can result in a fairly typical aberrant morphologies. Okay, so let's just kind of review some of these morphologies. So you have that typical right bundle branch block pattern, okay, where you see that RS, R prime complex in lead V1, okay. And it's that terminal late deflection that is making up that slow cell-to-cell depolarization as it heads more rightward and anteriorly. You have lead V6, okay, these slurred S waves that you're seeing there. And then we talked about in left bundle branch block, we see in lead V1, okay, these S waves or monophasic S waves or almost QS complexes with that slow terminal deflection down here in V1, as well as in lead V6, these almost monophasic broad R waves that are occurring here. Okay, you can also have a slowed R wave peak time that we'll learn later that could be helpful in differentiating some of these wide complex tachycardias. Okay, now atypical features of these bundle branch blocks, okay, that would be more characteristic of ventricular tachycardia. So in other words, what we're saying is if you have a wide complex tachycardia and it looks like a typical right or left bundle branch block, then it's most likely a supraventricular wide complex tachycardia. Okay, so QRS configurations representing the typical right or left bundle branch block configuration is most likely a supraventricular rhythm, okay, with some aberrant conduction. However, if you have configurations of these complexes that are incompatible, okay, so they don't represent, they're atypical of left or right bundle branch block, then it's most likely VT. And so what we're looking over here are these atypical features that are more likely characteristic of VT. So with that right bundle branch block morphology, things that would be atypical in V1 and V2 are these monophasic R waves, these QR complexes, so this is the Q wave and this is the R wave. And then another important point here is when that initial R wave is greater in amplitude than the R prime wave. So you can see that here. So this is your R wave, and then this one here is your R prime wave. Notice that the amplitude is less. So that initial one, if it's greater than the other, that may be characteristic of VT. If you looked at our typical right bundle branch block, notice that we had a small R, S, and then an R prime. Okay, so the R wave of the initial one was less than the R prime, which was different than what we're seeing here. Now in V6, that left lateral precordial lead in right bundle branch block morphology that'd be more atypical is when you have this RS ratio of less than 1. So here's your R wave and here's your S wave. Notice that the S wave amplitude is greater, okay? So you have less R. So imagine if your R amplitude was, let's say, 5 here, okay, and the S wave amplitude is maybe 7, you can see that that's less than 1. You may have a dominant Q wave, okay, in those leads. Remember that that's not typical of a right bundle branch block morphology. Notice here we have that slurred S wave, and then you can also see monophasic R waves, okay, that may be seen, and that is certainly not typical. So those features may be suggestive of ventricular tachycardia. Now, those with that left bundle branch block morphology that represent VT or atypical left bundle branch block pattern would in V1 and V2 have an initial R wave peak time pretty much of greater than 30 milliseconds. So that's saying from this beginning all the way to the peak of it is more than 30 milliseconds. Remember that one small box, the width of it is equal to 40 milliseconds, meaning that if that width is at least 40 milliseconds, that's suggestive of it, okay? Now, those, you may also see a pretty much an S wave, the R onset, the R wave onset, which is this wave here, to the S wave, nadir, the lowest point, if it's greater than 60 milliseconds, could also show it, as well as this notching here that we're seeing in the downstroke of that S wave. Okay, so that's another thing here, okay, or maybe a Q wave. But anyway, so the downstroke of that main deflection, if there's notching there, may be suggestive. And here in V6, what we're seeing are these small Q waves that are popping up there, okay, and then these QS or QR complexes in those leads would be more atypical. Okay, so just to recap, all these features that we've mentioned here on the right side are atypical of a normal bundle branch block pattern, and these findings would be suggestive of VT, okay, compared to these ones here. So hopefully that makes sense. All right, let's review what we discussed before we end here. So we're looking at the QRS morphological criteria. We're examining the QRS morphology, its configurations, to assess whether they are consistent or inconsistent with aberrant conduction. We said that if you see a wide complex tachycardia and it looks like a bundle branch block, okay, then in that case, it is most likely a supraventricular wide complex tachycardia. Okay, a wide complex rhythm that's originating from above the ventricles. However, the ones we want to catch are these ventricular tachycardias, and that's when you have QRS configurations that do not fit the typical right or left bundle branch block pattern. Okay, so you have a wide complex tachycardia. It does not appear as a normal bundle branch block pattern, and it may appear as some of the ones we mentioned here. Okay, those are the ones you want to be aware of, and those are the ones that may suggest ventricular tachycardia is present. Well, that's the end of this lecture. We discussed the QRS morphological criteria suggestive of ventricular tachycardia in differentiating wide complex tachycardias. I hope you learned something. Now, just to keep you in mind of our course material that we have available, so again, if you go to our website, www.ekg.md, okay, so this is our website, and what you'll notice is that if you go to the EKG course here, okay, you'll find stuff that's separate. So notice that we have a number of topics, practice material, lectures, a way for you to contribute, and this is the course here over here. So you'll notice we have over 300 videos or so, and that's more on YouTube. There's another 100, more than 100, about 200 videos that are available with the course. So those are separate videos, and this course is really designed to take you from a beginner to advanced interpreter. Okay, so completely separate from what you're getting online for free. Okay, these are course material that comes with it. So notice that you have a book. Okay, and then you also have the pocket guide available, so you can choose which format. They are the same thing, both these book and the pocket guide, different formats. I really like this small one because you can keep it in your white coat if you're in the clinic or in your pocket, and it's really available on the go. Now with the book, you also get videos. So notice these are the videos, okay? And these are a video for every single page in that book. So it's over 30 hours of video. Now there's a number of practice material that I continue to upload there. Okay, we'll have practice questions coming soon. So all of that's available. Again, this is separate from all the free material that you get already. Okay, so this is more high yield stuff. This is what we used to teach our technicians here and our students here at Mayo Clinic. And it's used now among many institutions. So check that out. Now, what it also includes are calipers. So yes, you get calipers with this course. Okay. I don't know anyone else that offers that, but you do get calipers. I think they're very helpful, and they can, if you know how to use them correctly, can help to identify different arrhythmias that are going on. Okay. And then you also get our pocket EKG reference. Okay, this was something we've put together as we were developing course for the fellows, and this is really nice. It has every code, as you saw earlier, laid out there. Very small pocket guide available. I had help with my colleague, Dr. Peter Noseworthy, who's the head of the EKG lab here at Mayo Clinic, in editing it. So this is something that we use, and we've found very helpful. So go to the EKG course. You'll see examples of lectures, okay, why we developed this, okay. A lot of it came about from myself struggling with learning EKGs, having a father that was an interventional cardiologist and, still struggling. So my struggle is a struggle that I don't want you to have in learning them, okay. You can read all those introductory books, but honestly, they are not enough, okay, and you find yourself using other resources, which is part of the learning process. I wanted to expedite that process for you and make it less inefficient in pretty much what I struggled with going and learning through EKG. So again, from beginner to advanced level with this course, you get the book, the calipers, the coding reference, video access, okay, and now we're offering 25% off. 25% off. Put that code in on checkout, and you'll have yourself 25% off that will even, it's pretty much covers the cost of what we use to print the material. So we don't really make much off it. It's more to help our learners grow and really be able to contribute to patient care. That's why we do this, and we love doing it. So thank you so much for your support. If you have any questions, just leave them below, and we're happy to answer them. All right, have a great day.